Hey everybody, this week we are talking about opioid abuse. The first question about assessment findings, the physical findings, and some of the nonverbal findings would be slurred speech, constricted pupils, an increase in the pain threshold, and possibly respiratory depression. Verbally, the patient may report to you that they have crushed a tablet to inject it IV, or taken the drug by another route other than what it was intended for. They may also mention that they've been to another doctor or another hospital, another ER, trying to get the same medication. They might just mention that in passing, and we recognize that to be doctor shopping. So that might be something that they also mention. And psychosocially, we can see a range from agitation, euphoria, depression. There's quite a range there. The behaviors that someone demonstrates when they're abusing opioid medications: drowsiness, mental confusion, nausea, constipation, and euphoria, or possibly signs and symptoms of withdrawal, which include excessive sweating, restlessness, dilated pupils, agitation, goosebumps, tremor, violent yawning, increased heart rate and blood pressure, nausea, vomiting, abdominal cramps and pain, muscle spasms with kicking movements, and weight loss. They also have if they're addicted, you will see a greater tolerance to the drug, which is that greater amounts of the drug are needed to obtain the desired effect. Or that using the same dosage of the drug does not produce the same effect that they were getting. Also, a closely related substance can be taken to relieve or avoid withdrawal symptoms, and in the case of opioids, a lot of times they'll use methadone. That seems to be the most common one. There are a couple of others, but methadone has been used for 40 years for that. They also will be using the substance in larger amounts or over a longer period that it was intended, and taking larger doses than prescribed, frequently running out early before their prescription is due to be refilled. There's a persistent desire or unsuccessful efforts to cut down or control the substance use, and a lot of time is spent trying to obtain the drug, use the drug, or recover from the drug effects. Important activities are given up due to substance abuse, and the user continually uses despite knowing that they're experiencing adverse effects. For example, depression is common with opioid abuse, and the user will continue to use the opioid despite knowing that their depression is caused by that abuse. The pathophysiology of opioid abuse. It's important to know that over time the body's cells are tricked into believing that it's normal to have the drug present in the body, and that's where the tolerance comes in, and then that's going to be where the withdrawal comes in also. Opioids act by binding to receptors on neurons in the nervous system and in the immune system, and these receptors are the binding sites for several peptides that govern a list of functions: pain, stress, temperature, respiration, endocrine activity, gastrointestinal activity, mood, and motivation. And all of those are things that, areas where you see signs and symptoms of use and abuse as well as withdrawal. These receptor sites are also stimulated by endorphins, which generally produce a sense of well-being, and that's where that psychological dependence comes, because the person enjoys that sense of well-being or euphoria. Used long-term, opioids have been found to change the gray matter of the brain. The best practice interventions that healthcare providers can implement to manage prescription drug abuse and/or addiction. And I am sure that all of you have the same process that we do when we are admitting a patient. We go through the list of the drugs that they are currently using, the prescription drugs. We also ask about over-the-counter drugs, supplements, herbal supplements, vitamins, minerals, anything. We ask about all drugs, and the rationale is that this helps the patient recognize if there's a problem It helps to set recovery goals and seek appropriate treatment. Another thing that we do is we notify the doctor if we notice rapid increases in the amount of medication needed or frequent unscheduled refill requests. And that is definitely something that we do where I work at the hospice house, because there's one doctor for a massive amount of people, and we are expected to help stay on top of things like that. We are to notify the doctor if the patient mentions going to other doctors for the same medication, if they're doctor shopping. And a big thing that we do is teach the patient. We should be teaching the patient to always follow the prescribed directions, never stop a change of dosing without first discussing it with their doctor, and be aware of potential interactions with other drugs, and to never use someone else's prescription. In my practice, which is I'll address it through the hospice house, because that's just a little different. We don't focus as much on addiction with our patients as we do pain control, for obvious reasons, for comfort measures. We focused on addiction more when I work, and I still work sometimes on a hospital floor. But we do have long-term patients in hospice, and they do sometimes get addicted to their pain medication. And normally we'll recognize it because they start calling and asking for refills on their prescription before it's due. The protocol at that point, the doctor will call and talk to the patient over the phone, and talk to them about how much they're using and what their pain feels like, and try to assess the best they can over the phone. If they see that there's a problem, if they think that they've become addicted, they don't generally say that to the patient. What they say is, I'd like to have you come in and stay a few nights at the hospice house for pain management. And that is the diagnosis that they're giving, is that we're treating them for pain management. And once they're admitted, the doctor begins tweaking their medications, maybe weaning them off one, trying another one. And sometimes if they're really close to death, there isn't a whole lot that's changed. Whatever they need to do to put the patient in comfort is the main concern at that point. Our biggest dilemma with opioids through hospice is probably the diverting of drugs by someone who is in the home. Each patient is given a comfort care kit, and it's locked, and usually the patient or someone else in the home will report to the nurse that there's someone that's using the drugs. It could be a grandchild, somebody that has that they've had problems with. They'll say things like, well, I don't want my grandson to come by because he takes my medicine. And they will just come outright and tell you that that's a problem. Another way that they find it is that the nurse that's assigned to visit that patient in the home, they either see the activity going on. They may see someone who's acting like they're under the influence. They notice that medications are missing. Another thing they may find is that when they medicate the patient and they're there for a while, the medication works as it should. When the family is medicating the patient or a caregiver, the patient is reporting pain or that the symptoms are not being controlled. And that is when we start to look at possible drug diversion in that case. So that's it for this time.